Hello, everyone, and thank you for joining us today. My name is Casey Volpe, and I am with Susan G. Komen's Community Education and Outreach team. And today you are joining us for our third MBC Impact Series event, our third in the four-part research series. I apologize. So the programming for the Impact Series is envisioned as a year-long conversation with attendees where we cover new topics and new speakers every month. And today we'll be hearing from Dr. Ian Kropp about HER2-positive metastatic breast cancer. Before we begin, Komen would like to thank our sponsors for supporting the 2023 MBC Impact Series events. So first, thank you AstraZeneca for being our technology sponsor for this year's events. The virtual setting means that MBC patients, no matter where they are, can be part of this community. We also would like to thank our premier sponsor, GE Healthcare, and our signature sponsors, Walgreens, Daiichi Sankyo, Sanofi, and Merck. The series is made possible because of them. On a housekeeping note, while our speakers are talking, please post your questions in the Q&A feature in Zoom, and we will be sure to get to as many as we can at the end of the presentation. Towards the end of our program, a survey link will also be placed in the chat. Your feedback is very important and helps us plan program topics, speakers, etc. So it's really important. We like to hear directly from you guys. So please complete the survey, and by completing the survey, you'll be entered into possibly winning a $25 Amazon gift card. So we're very excited to get started. There's lots to cover. So I'm going to get us kicked off by introducing you to our moderator, Rebecca Seago-Coyle. Rebecca is a 13-year breast cancer survivor diagnosed in 2010 at the age of 35 with early stage ER-positive, HER2-positive, and BRCA2 positive. Working in IT for almost 20 years, she has a passion for technology and now the impact technology has on healthcare. She leverages her organizational skills and her advocacy, ensuring projects she's involved in move forward and ultimately help patients. With a strong family history of breast cancer in her family, Rebecca was inspired to advocate for breast cancer research, specifically for young women who are newly diagnosed like she was. Her volunteer and advocacy work has only grown over the years, advocating for several national organizations and providing the patient perspective to researchers and clinicians. So, Rebecca, the floor is yours.
Thanks, Casey. Thanks, everyone. I'm happy to be here, and I'm really looking forward to Dr. Kropp's presentation and learning a little bit more about metastatic HER2. While I was early stage, I still like to stay up to date on the latest and greatest with the different treatments out there, just in case something happens with myself or something happens with one of my friends and colleagues that I can help redirect them. So with that, I will introduce Dr. Kropp. So Dr. Ian Kropp is an international leader in the clinical care of patients with breast cancer. He joined Yale from Dana-Farber Cancer Institute, where he was the associate chief of the division of breast oncology and an associate professor of medicine at Harvard Medical School. Nationally, he serves as the Chief Scientific Officer for the Translational Breast Cancer Research Consortium and the co-vice chair for correlative science for the Alliance for Clinical Trials in Oncology. His research efforts have advanced the field through clinical trials that define the next generation of therapies for patients. Dr. Kropp serves as a member of the NCI Breast Cancer Steering Committee and the Data Monitoring Committee for ECOG and ACRIN. He also serves as the Data Safety Monitoring Boards for multiple phase 3 trials. Dr. Kropp, thank you. And you're on mute.
Yeah, yes. Thank you, Rebecca, for that introduction, and thanks to Casey and Susan G. Komen for inviting me to talk with everybody today. I'm going to share some slides, and I feel very fortunate to talk about HER2-positive breast cancer. This is an area that's, as many of you know, and as I will share, is fortunately an area for which there's been a tremendous amount of progress in new treatments and new understanding of how this type of breast cancer really develops and works. So this is an exciting time to be talking about this area. So let me, as I said, I'm going to go through some slides, and then we want to, both Rebecca and I want to leave a lot of time for discussion, because we're really trying to make sure everybody gets their questions answered. So we're all on the same page, just very quickly, because the term metastatic gets tossed around a lot, Some people also use the term advanced breast cancer. Just so we kind of level set, what that means is just breast cancer that's spread from the breast and lymph nodes to other parts of the body, and that can be basically any part of the body, and that is defined as metastatic or stage 4 breast cancer. Those two things mean the same thing. And for most patients who have metastatic breast cancer, it occurs after they were initially diagnosed with breast cancer in the breast and potentially their lymph nodes, and they had breast surgery and oftentimes some other type of medical treatment. But then, unfortunately, the breast cancer recurs in other parts of the body. That's the most typical presentation. But in a small percentage of people, people can actually present the first time they're diagnosed with breast cancer. It's in other places. So that's called de novo metastatic breast cancer, and it's just a term that just kind of gives us a sense of how that person's disease presented itself. There's nothing bad about de novo disease per se. It's just a different way that the cancer presents. And there are about 150,000 patients who are living with metastatic breast cancer in the United States right now. The number probably actually is a little higher these days because this is slightly older data. And since the treatments have gotten better, we have more patients living with this disease. And there are many treatments available right now for all forms of breast cancer. Now, the dogma has been that these treatments, despite there being a number of them, are not generally curative, meaning that we don't think we can get rid of every last cancer cell in a patient who has metastatic disease. And so people who have metastatic disease typically get treated indefinitely, and I'll talk about that. I'll also talk about the fact that this idea that metastatic breast cancer cannot be cured is probably not accurate, and it's getting less and less accurate as the treatments get better, and we'll talk a little bit about that as well. So how do we treat metastatic breast cancer? Again, because our treatment is not curative, people generally need to stay on treatment indefinitely. And that often means that they're going to have to change treatments over time. So we generally start with one treatment, and people stay on that treatment for as long as the drug is working, or somebody develops really side effects that are really not manageable. And for one of those two reasons, we switch to therapy number 2 and then stay on that for as long as it's effective and safe, and then switch to therapy 3 and so on and so on. In general, those therapies have in the past been chemotherapy. So chemotherapy 1, then chemotherapy 2. But that changed with the realization that breast cancer isn't just one single disease, but actually multiple diseases. And each of these types of disease, each of these types of breast cancer has its own behaviors and drivers and vulnerabilities. And it was that realization that breast cancer is a number of different diseases and that there are different vulnerabilities that we can take advantage of that has led to the real progress that's been made in breast cancer over the last 25 years or so. And the HER2 positive disease is the one for which we really is the most dramatic benefits, and we'll focus mostly on that. I will just mention that while we typically had thought of breast cancer as being either estrogen receptor positive, driven by estrogen, or HER2 positive, driven by HER2, or triple negative, which didn't have either of these two drivers, we now also realize that there's a kind of intermediate group called HER2 low that we can talk about more at the end, since it's probably the newest kind of subclassification of breast cancer. So we're focusing on HER2 positive disease. So we should talk about what HER2 is. So HER2 is a protein. It's a normal protein. It's on a lot of cells in the body normally. And its job is to tell the cell to grow and to be resistant to dying under situations of stress. So normally HER2 doesn't do much, it sits on the surface, but under situations of stress, it sends signals into the nucleus of the cell to tell the cell to, kind of get stronger so it can, survive this, whatever the stress is. Now, normally there's about 10,000 or a few thousand copies of HER2 on each cell. But in this small population of breast cancers called HER2 positive, because of a mutation, an alteration in the gene that codes for HER2 protein, as that cancer is growing, you get too many copies of the HER2 gene, and that leads to too many copies of the HER2 protein. So in a HER2 positive cancer, which we often also call HER2 amplified, instead of having a few thousand copies of HER2, you have a few million copies of HER2. So for each cell, as you can see in this kind of cartoon, is essentially covered with these HER2 proteins. And as I mentioned, the job of HER2 is to tell the cell to get stronger under situations of stress. And so if you have a million of these proteins all telling the cell to get stronger and be resistant to dying, then that's what the cancer does. It grows quickly, it's resistant to some therapies. And so it used to be that a HER2 positive cancer was a diagnosis that we really hated to give, because these HER2 positive cancers tended to grow more quickly, they tended to recur more often, and our treatments didn't work as well. But the realization that the reason these cancers were behaving badly like this was because of the HER2 led to the development of drugs targeting HER2. And that's really changed entirely how we think of these kinds of cancers. And now people with HER2 positive disease actually generally do better than people with other kinds of breast cancer because of the new therapies, which I'll get to. But just before I leave this slide, I just want to point out again that while a HER2 normal or HER2 negative cancer may have a few thousand copies of HER2 on them, and a HER2 positive cancer like this one has a few million, a HER2 low cancer is kind of in between, and it probably has 50,000 copies of HER2. So more than a negative, we call it negative, but really probably means very little. More than those HER2 negative cancers and less than the HER2 positive cancers, so in the middle. So that's what HER2 low means, kind of intermediate levels of HER2. And again, we can talk about that later if people are interested. Okay, but let's talk about the HER2 positive cancers, the ones that are really driven by HER2. And that realization led to drugs targeting HER2, and the first one of those was a drug called trastuzumab, or often known as Herceptin. And basically, Herceptin is a monoclonal antibody, which means it's a factory-made, a synthetic protein that's one job is to go through the body and stick to the HER2 protein. So it's exquisitely specific for that HER2 protein. And the way these antibodies are made, they're kind of these Y-shaped structures, and what determines their specificity is this thing at the bottom of the Y, which is called the binding domain. And that is, again, exquisitely specific for HER2. It won't bind to anything else in the body. So when you give trastuzumab or Herceptin to a person who has HER2 positive breast cancer, the antibodies will go through the blood, find all the HER2 on the surface of those cancer cells and stick to it and inhibit that HER2 protein. And what that meant was that, particularly when combined with chemotherapy, trastuzumab essentially makes the chemotherapy dramatically more effective. It doubles the time that the chemotherapy can control the cancer. It improves survival compared to chemotherapy without trastuzumab. And because it's so specific and so targeted, it has really very minimal side effects. For most people, it really doesn't have any side effects that one notices, with the rare exception that it can cause weakening of the heart muscle, which is certainly a serious side effect, but we don't see it very often anymore, because most of the heart damage that was seen with trastuzumab happened when you combine it with specific chemotherapies. And we don't use those chemotherapies as much anymore. And we almost never use them in the metastatic setting. So heart damage is really quite unusual now when used with trastuzumab. So for the most part, trastuzumab provides a lot of benefit and very little in the way of side effects. So this was a real breakthrough and really changed the natural history of this kind of cancer, and it led to the development of other drugs. And the reason why it needed to lead to other drug development was because in patients with metastatic disease, despite trastuzumab working so well, most patients eventually develop resistant disease that's somewhat resistant to trastuzumab, or at least resistant to trastuzumab when combined with a specific chemotherapy. Now, why that resistance develops is unclear. These cancer cells, even though I make the cartoons look very simple, with a little lightning bolt in, that little lightning bolt is actually a huge number of different proteins on multiple different pathways. And so you get this real complicated kind of structure as shown in this diagram here. And you can have resistance through multiple different pathways like this. So it's been very hard to understand completely how cancers can become resistant to drugs like trastuzumab. But we are making progress, but despite not really understanding completely how resistance happens, we've been able to make drugs that are able to overcome this resistance. So right now, how do we treat metastatic HER2-positive breast cancer is not so much giving one chemotherapy after another, but giving one HER2-directed therapy after another. But still, resistance develops at each of these points, and that's why we need to change therapy. So there's still plenty of room to do better than what we had been doing, and fortunately these newer drugs have been helpful in that they're oftentimes more effective than trastuzumab alone, and they continue seemingly to get better and better with each new generation. So I'll walk you through some of the other drugs that we use now, many of which have just been approved in the very recent past. So one of the first of these other drugs to be developed was a drug called pertuzumab, which, as you can see, seems very similar to trastuzumab, and that's because functionally it's another antibody that binds to HER2. It binds to a slightly different place in the HER2 molecule. You can see the trastuzumab binds in the green there, binds down here on HER2 close to where the cell membrane is, and pertuzumab binds higher up. The only reason that's important is because by binding in different places, it's able to block more of the function of HER2. And so if you combine trastuzumab with pertuzumab together, they work better than just using trastuzumab or pertuzumab alone. And that's why for most patients who are newly diagnosed with HER2-positive metastatic breast cancer, we give chemotherapy with both trastuzumab and pertuzumab because they work better than either one of those two antibodies by themselves. So that was a big improvement. It improved survival by about 30% and improved disease control by about 50%. So that again was another further improvement in how well these drugs work. Pertuzumab has a few more side effects than trastuzumab for many patients. It can cause more diarrhea, it can cause some rash. Usually those are manageable, but adding pertuzumab to trastuzumab does add to side effects, particularly when there's chemotherapy around. So there is a cost to adding pertuzumab. But again, those benefits outweigh those costs for most patients. Things didn't stop there. We have a whole new category of drug that got developed around 2012 or 2013 or so, and that ushered in a whole new class of drug called an antibody drug conjugate. And the first of these was a drug called TDM1 or Kadcyla. And what an antibody drug conjugate is starts out with an antibody, in this case trastuzumab, and so you guys are all now pros about what trastuzumab is. Again, here's our antibody that binds to the HER2. But as I mentioned, trastuzumab works best when combined with chemotherapy. Essentially, the trastuzumab, by blocking HER2, makes the cells more vulnerable to chemotherapy because it's shutting down that survival signal that the cells were getting from the HER2. So it makes them more vulnerable to chemotherapy, and that's why it's better to give chemotherapy with trastuzumab than just trastuzumab alone. But when you give chemotherapy, when you give an IV bag full of trastuzumab, which is super targeted to the cancer cell, and then you give an IV bag of chemotherapy, which isn't targeted at all, you lose some of that specificity, and that's why chemotherapy plus trastuzumab still has all the side effects of chemotherapy. It's targeted, half of the regimen is targeted, the other half is not. So you still get all the non-targeted effects of chemotherapy, which can attack the cancer cell, but of course also can hurt normal cells as well, and that's why you get side effects. So the idea of the antibody-drug conjugate was a way to try to get around that problem. So what an antibody-drug conjugate is it's an antibody given with chemotherapy, but instead of giving them in two separate bags, you actually link the chemotherapy to the trastuzumab. So you actually attach the chemotherapy molecules to the trastuzumab. So in this case, TDM1 consists of trastuzumab, that's the T, combined with a very strong chemotherapy called DM1. DM1 is what's called a microtubule inhibitor. It's kind of like Taxol or Taxotere that some people may have been familiar with, but it's a very strong chemotherapy, much too strong to be given by itself. But the idea is if you link it to the antibody, it works somewhat like this. So the antibody drug conjugate, the TDM1, binds to HER2 because it's essentially based on Herceptin or trastuzumab. Then the whole thing gets brought inside the cell. And once inside the cell, the antibody gets degraded by the cell. And that allows those little chemotherapy molecules to be released from the TDM1, get inside the cell, and kill the cell. So the idea here is you're able to very specifically deliver the chemotherapy right to the cancer cell. And because the chemotherapy is attached to the antibody, it's not able to float around the bloodstream and damage normal tissue. So it's kind of like a guided missile approach. And by directly targeting in the specific way the chemotherapy to the cancer cell, you're able to get a lot of effectiveness, but you're cutting down on the side effects because the chemotherapy is targeted to the cancer cell. And so what we see when using TDM1 is in patients whose chemotherapy and trastuzumab had already had resistance develop, that TDM1 caused substantial shrinkage of cancers in 40% of patients and improved survival by about 30%. So that's beyond what we already saw with some of the other drugs. And because it's so targeted, you don't get the usual chemotherapy side effects, even though it really is a chemotherapy-based drug. So people don't lose their hair. Nausea is uncommon. Certainly severe nausea is very uncommon. You don't have lowering of blood counts for the most part. You don't get neuropathy. You do get some laboratory abnormalities, like some people can get lowering of their platelet count, which is their blood clotting cells, and they can get slight irritation of the liver that we see in lab tests, but those usually don't cause any symptoms for patients. They're just something that we pick up when we do our blood tests. And sometimes we have to adjust the dose or wait an extra week, but they don't usually affect people's day-to-day activities. So this really was a true breakthrough in not only improving effectiveness of the prior drugs, but also really cutting down the side effects. So this idea of an antibody drug conjugate really turned out to work the way we had hoped it would work, which was a very effective drug with fewer side effects than chemotherapy. And the success of TDM1, which was the first of these kinds of drugs that were approved in any type of solid cancer, has led to the development of a whole range of these antibody drug conjugates, which are now one of the more hottest area in cancer drug development. Not only did it lead to development of other antibody drug conjugates in other cancers, but also led to second generation conjugates for HER2 positive disease. So the next one of these was called trastuzumab deruxtecan, or in HER2. So again, as you can imagine from the name, it's still the same trastuzumab antibody, but instead of DM1 being the chemotherapy, in this case, the chemotherapy is called deruxtecan. It's a different class of chemotherapy. So even if a cancer got resistant to the DM1 type of chemotherapy, the hope was that it wouldn't be resistant to this new kind of chemotherapy, the deruxtecan payload. And in addition to the fact that the chemotherapy was different and a little bit more potent, it has some other differences compared to TDM1. first off, there were twice as many chemotherapy molecules for each antibody. So each time the antibody, one of these drugs, hits a cancer cell and binds to a cancer cell, it's delivering twice as much chemotherapy as the TDM1 did. But the other kind of interesting feature is that it has something called bystander effect, and I'll tell you about that. So when in this case, when the antibody, the conjugate binds to the HER2, it gets inside the cell and it releases the chemotherapy into the cell, just like the TDM1 did. In TDM1, that chemotherapy molecule is stuck within the cell. It can only damage that one cell. But because in this case, the chemotherapy is a little different, with TDXD or trastuzumab deruxtecan, those chemotherapy molecules can go outside the cell and they can kill neighboring cancer cells, even if these neighboring cancer cells don't have any HER2 on them, because now they're not being directed by the antibody; they're just floating around in the neighborhood there, and so they can kill neighboring cancer cells. And you may wonder, well, why is that important? Because the whole point of this was to target the cancer cells with the antibody. Well, so it turns out that in some cases, in some tumors, not all the cancer cells are uniformly expressing HER2. So we call that heterogeneity. And what that means is that you have a situation where half the cancer cells make a lot of HER2, and because of another mutation or alteration, other cancer cells don't make as much HER2. So in just my little cartoon here, you can see the idea would be that if you have a cancer that's a mix, that's heterogeneous, so you have the blue cells are HER2 positive, the red cells are HER2 negative, and you treat with a very targeted drug like TDM1, you can kill off all the blue HER2 cells, but you leave behind the HER2 negative cells, and those can now grow. And so that could theoretically decrease the effectiveness of a drug like TDM1, which is very exquisitely targeted. And we actually did a trial a few years ago to kind of test this idea, where we were asking the question of, does this non-uniformity, the heterogeneity, affect the effectiveness of drugs like TDM1? So we took 140 or so, 160 patients who had newly diagnosed HER2 positive disease. So the cancer was confined to their breast, and treated them. They volunteered to go on this trial to receive these very effective HER2 therapies, the TDM1 plus pertuzumab, and then they had their surgery. And what we found was in the cancers that were uniformly expressing the HER2, so not heterogeneous, 55% of those cancers completely went away when treated with the TDM1. So we knew that TDM1 was effective, and this confirmed that in these cancers that uniformly express HER2. But then when we looked at the cancers that were heterogeneous, so there was some cells that were positive, some cells were negative, none of those cancers went away. So that really brought home this idea that this heterogeneity could decrease the effectiveness of drugs that didn't have this bystander effect. The hope was that these newer drugs that have bystander effect would be able to overcome this heterogeneity. And it turns out trastuzumab deruxtecan does seem to do that. So as opposed to TDM1, which had tumor shrinkage in 40% of patients, and TDXD causes shrinkage in 80% of patients, it delays cancer progression 4 times longer than TDM1. So compared to roughly 7 months, it controlled cancers on average by 28 months. So a huge difference, and improved survival by 35%. So even though trastuzumab deruxtecan uses the same basic idea as TDM1, it's much more effective, and has become the new standard for people whose cancers has learned to be resistant to trastuzumab, pertuzumab, and chemotherapy. And just to show you another way of looking at this, this was one of the more recent studies that was done, and each of these blue lines is a patient who was treated on the study, and this is how much their cancer shrank. So this middle black line here is no change, and you can see that I think it was 97 or 98% of patients had the cancer shrink at least somewhat. 20-something% had their cancer completely go away. These are metastatic patients. 20-something% had their cancer completely go away. Almost all of them had substantial shrinkage, and only 3 or 4 or a couple % of people had their cancer actually start to grow despite the trastuzumab deruxtecan. So you can see this really is effective in almost everybody with HER2 positive cancer. It does have more side effects than T-DM1, perhaps because it's more potent and perhaps because the bystander effect, you lose some of that specificity. So nausea, vomiting are very common with T-DXd. It definitely is treatable with our usual nausea medicines, but you have to take the nausea medicines, or many people have to take the nausea medicines where you don't really need to do that with T-DM1. About 30% of patients have hair loss with T-DXd, and a serious side effect called lung inflammation or pneumonitis can occur in about 10 to 15% of patients. So we definitely have to monitor for that, because if it gets serious, it can actually be fatal. So definitely something that has to be kept an eye on with this drug. But for most people, the substantial improvement in effectiveness outweighs the side effects. Now, just switching gears a little bit, to point out that unfortunately people with HER2 positive breast cancer, metastatic breast cancer, are at higher risk for having cancer cells go to the brain. Brain metastases are more common in HER2 positive disease than in some other kinds of breast cancer. Radiation is a very effective way of treating brain metastases, but sometimes the cancer can grow, can progress, and recur after radiation to the brain. And that some of our therapies appear not to be as effective in treating brain mets as they are for treating other sites of disease. And there's several potential reasons for that. But that's led to interest in trying to develop drugs that would be more effective in the brain. And as I mentioned before, HER2 is a signaling protein that works by sending signals into the nucleus. And there's a new drug, or there's actually several drugs, the most recent of them is called tucatinib, which are pills that are able to go inside the cell and block that signaling. So it's another way, instead of having an antibody that binds to the outside of the cell on HER2, this binds to HER2 on the inside of the cell and blocks that signaling. And it's shown to be very effective as well. It also improves survival by about 40% compared to giving trastuzumab and chemotherapy. It's effective in about 50%. It improves survival in patients with brain metastases by about 50%. It causes substantial shrinkage of brain metastases in about 50% of people as well. So it also has been a very welcome addition to our list of effective drugs, particularly in patients with HER2 positive brain metastases. It does have side effects. It can cause diarrhea. It can cause rash when combined with the usual chemotherapy that we give it with, which is called capecitabine or Xeloda. So those are some of the newest drugs that we are now using very frequently in the clinic. There are a few other ones as well. We have 8 drugs now available to us that are FDA approved for HER2 positive disease. But I just wanted to kind of go through some of the questions that are being asked these days. Again, we already talked about why tumors develop resistance. We don't really know the answer to that in most cases, but fortunately, many of these drugs are able to overcome some of that resistance. How do we develop better treatments for metastatic HER2 positive disease? I'll talk about that in a minute. How can we treat brain metastases better? And then there's some really interesting questions about, can patients have long-term disease control off treatment? As I mentioned, we treat generally HER2 positive disease as not curative and with a plan to give one treatment after another, but there are some reasons to think that might not always be the case. And the way we answer some of these questions is by clinical trials as well as laboratory work. And I just wanted to mention that one group in the US is trying to answer some of those questions with clinical trials, and that's called the Translational Breast Cancer Research Consortium, or the TBCRC. As Rebecca mentioned, I'm part of this group. It's made up of 18 universities in the US, and we've been working together since 2005 to do clinical trials specifically in targeted forms of breast cancer. And I just wanted to point out that Komen and BCRF, which is another foundation, have been funding the the TBCRC since it was initiated in 2005. So certainly without the help from Komen, we wouldn't be able to have done any of these trials. I just want to tell you about two trials specifically in HER2 positive disease that I think are pretty important, not only for the particular trial, but it tells you a little bit about where we are right now in HER2 positive breast cancer. So the first one is called Stop HER2. And it's asking this question, and I'm sorry, this is not a very easy to read chart, but I couldn't find a better one. This is basically taking advantage of the fact that it looks like about 20 to 25% of patients who have newly diagnosed metastatic HER2 positive breast cancer and are treated with chemotherapy and trastuzumab and pertuzumab are able to stay on those drugs essentially indefinitely. Not the chemotherapy part, but they usually we stop the chemotherapy and we continue those two antibodies, the trastuzumab and pertuzumab. And something like 20% of patients, if you look out 8 years or more out after starting those drugs, the drugs are still working and the cancer still seems to be well controlled. And so that always brings up the question in the clinic, well, maybe those patients really are cured and they don't need those antibodies anymore. And we never know what to do because there's never been a clinical trial to ask this question of, is it safe to stop the HER2 therapy? So this trial is asking that question. It's the first trial asking that question in a kind of careful way. There are definitely a number of reports of patients who have stopped their trastuzumab or their trastuzumab and pertuzumab and have not had the cancer ever come back. But we don't have enough data to tell a given person, hey, this is okay to do or it's not okay to do. So that's why we're doing this trial. And it's asking patients, are they interested, who have their cancer been controlled on their first regimen of therapy? Has it, are they interested in stopping after at least 3 years of disease control? And the patients who are interested in stopping will stop the HER2 therapy, and they'll be followed closely every 12 weeks with CAT scans and some very sensitive blood tests, essentially for 10 years. And looking at how many of those patients never have their cancer recur. If their cancer does recur, they would go back to restart their trastuzumab and pertuzumab. And obviously we'll need to make sure that that still works for those patients. If they aren't interested in stopping their HER2 therapy, we'll still observe them. They'll continue their HER2 therapy, and we'll look at how those patients do as well with the same kind of follow-up to see, to get a sense for the first time of what happens when you stop HER2 therapy in these patients for whom it looks like the treatment has been so effective that the cancer may never come back. So, I think it's very important that we do this trial so that we can tell the next generation of patients that it is or is not safe to stop the HER2 therapy. And by doing some of these very sophisticated molecular tests on the blood, looking for minute quantities of cancer cells, hopefully that will give us some additional information that we can use in the future for such patients. But, I think this is a sign of how well patients are doing overall, that we can start asking questions in metastatic disease of stopping therapy altogether. A related question, again, comes from this idea that right now, metastatic breast cancers is considered incurable, and we give one therapy after another. Now that we have 8 different HER2 therapies, and as I mentioned, 2 of them, the trastuzumab deruxtecan and the tucatinib, and we talked about pertuzumab and T-DM1 as well. Now that we have all of these highly effective therapies, maybe this kind of regimen where we just give one, we start a therapy, wait for progression, then start another, maybe that's not the best approach. Maybe we need to take advantage of the fact that we have all of these therapies that each can work in resistant cancers, and that because they work differently, maybe a cancer that's resistant to one won't be resistant to another. We should take a different approach. And so that's led to this other trial that the TBCRC is starting now, which is really asking this fundamental question of whether we can cure HER2 positive metastatic breast cancer. And so the way this trial is being designed is that in patients with newly diagnosed HER2 positive breast cancer, and this is looking specifically at these de novo patients, the patients who never had treatment in the past, because we think those are ones that are going to be the most sensitive to this kind of approach, they would, instead of giving treatment and then just waiting for the cancer to develop resistance, we give our best treatments one after another. So we give 12 weeks of the chemotherapy with trastuzumab, pertuzumab, and then give these antibody drug conjugates like TDM1 and trastuzumab deruxtecan. We're going to give them along with that other pill I mentioned, tucatinib, which works on the inside of the cell. And after completing a year of this treatment, or a little bit more than 1 year, we're going to stop treatment and then follow patients with the idea that we think with these highly effective therapies, all given one after another, that we hopefully can eradicate all the cancer cells from a person's body, and they will never have a recurrence of their disease. And so the goal of this trial is to identify the percentage of patients who go through this treatment and don't have any evidence of cancer recurrence for at least 4 years after stopping the therapy. So again, it's an ambitious study, but we do think that because there's been so much progress, that it's worth asking this question for patients who are interested. So I'll just close by reminding you that the only way we can do all of these, that we've made progress so far with all of these new drugs, is to do clinical trials. And these clinical trials are available for patients, not just for patients who don't have treatment options anymore, but at any step in their journey. We have trials for newly diagnosed patients, as I just mentioned. We have trials for patients who've been on 1 treatment, who've been on 2 treatments, essentially all along the way. And there are multiple benefits to being on a trial. You get a larger treatment team, typically with both your regular doctor and nurse, but also research staff as well. You can get exposure potentially to very cutting edge, the newest medications. And of course, you'll be helping not just potentially yourself, but all the future patients who come along with breast cancer. And as I mentioned, none of the advances that I just talked about would have happened without people volunteering to be in trials. So just to conclude, there are now fortunately many effective agents to treat HER2 positive metastatic disease. A number of them have just been approved within the last couple of years, and there are more in testing and clinical trials. We can start thinking about the idea of curing patients with metastatic disease. And as I mentioned, we think that there is a percentage of patients who are already cured with our standard HER2 therapies. And that's why we're stopping HER2 therapy in those patients in the first trial I mentioned. And lastly, again, none of the advances in breast cancer could be made without participating in trials. So I will stop there, and happy to take questions. Rebecca.
Yes, we have several questions. Thank you so much, Dr. Krop. That was really informative and a lot of good information. We have several good questions that we want to get answered. So first question for you, this came up a couple times, but besides cancer cells and normal breast cells, what other parts of the body have the HER2 protein? And does HER2 therapy interfere with those other cells? Yeah, so that's a great question. And so, yeah, so it's not just normal breast cells that have HER2. HER2 is basically on most what we call epithelial tissues. So that's basically it's tissues that line various structures and have ducts. So it's in the skin, it's in the lung, it's in most parts of the body have, other than like muscle cells and bone, and blood, most parts of the body have some HER2 on them, but they have such small amounts of HER2, and they're usually not dependent upon HER2. So the HER2, as I said, is there for stress protein, for stress situations. And so under normal situations, the HER2 really doesn't do much. So drugs like trastuzumab and pertuzumab and tucatinib don't have a lot of effects because even if they're blocking HER2, it's not really that important. The exception is in the heart, where there is a small amount of HER2. And what happens is if the heart is under stress at the same time you're giving a HER2 therapy, it can lead to this heart damage that I mentioned.
That's very rare. It's made worse when you give a chemotherapy that also stresses the heart. Drugs like adriamycin or anthracyclines, those themselves stress the heart. So that's why the combination of one of those chemotherapies plus trastuzumab or Herceptin is more likely to cause heart damage than if you use other kinds of chemotherapy or you don't use chemotherapy. But again, it's a rare thing, and we don't use those chemotherapies as much anymore because of that.
Right. So kind of leading on to that too. So can any of the drugs used for other subtypes of metastatic breast cancer, like can they also provide benefit for HER2 positive patients?
Yeah. So, the chemotherapy we use for HER2 positive breast cancer, like Taxol, that works in other kinds of breast cancer as well. People who have estrogen receptor positive, HER2 positive breast cancer, which is about half or a little bit more than half of all HER2 positive breast cancers, those can benefit from anti-estrogen therapy as well. So, certainly drugs like tamoxifen and anastrozole, those anti-estrogen therapies that we give for other breast cancers can work in HER2 positive disease as well, as long as the HER2 positive breast cancers also have estrogen receptors.
Okay. So one of the questions from Facebook Live was, what happens when a cancer antigen is 40.3?
I'm not sure what cancer antigen they're talking about. And,
okay.
Sorry, there's lots of cancer antigens, and there's tumor markers like CA2729 and CA15-3. Those can be, but I don't know what 40 point. I'm not sure which antigen that person's asking. If they want to clarify in their question, I'm happy to answer that.
Okay, thanks. We'll come back to it if we get that clarification. Are there any drugs that are currently in development that may be available in the near future, potentially within the next year?
So there is another antibody drug conjugate that's like TDM1 and TDXD. There is another one that has has already had a positive large trial. That drug is called trastuzumab duocarmazine. So again, it's same trastuzumab, but now it's yet another chemotherapy that's attached to it. So these antibody drug conjugates, we think they're just going to be one after another. They're just going to, we'll just keep there can be, by changing the chemotherapy component, you're essentially making a new drug. So there's another one of those with a different kind of chemotherapy. And that is being reviewed, my understanding is being reviewed by the FDA. And hopefully that would potentially give us another one of these antibody drug conjugates. And then there's a number of other drugs that are a little bit earlier in development that probably won't be approved in the next year.
Okay. So for patients that do the curative treatment trial, will they be completely out of treatment options if they have progression afterwards?
So that's a great question. It's an important question. In general, if a cancer hasn't progressed on a specific therapy, so let's say you give, 12 weeks of TDM1, for example, and then 3 years later, the cancer comes back. We certainly would be willing, we would give TDM1 again there. We give, many patients who get Taxol and Herceptin when they're initially diagnosed, and then if they have a metastatic recurrence 5 years later, Taxol or Herceptin can certainly be very effective there. So, the idea would be you could use those same drugs again because the cancer hasn't developed resistance on any particular one of those. But it is a question that we need to, that we'll need to answer in that trial. Hopefully nobody will have a recurrence. I think that's unlikely. I think some people are going to have a recurrence despite getting all of those drugs. But the hope is that there's going to be a large number of patients who never have a recurrence. And that's the question that's being answered. But not only whether they have a recurrence, but then if they have a recurrence, will it respond to those different drugs? And we can't guarantee it will, but of course we can't guarantee any cancer is going to respond to any specific treatment.
Right. So here's something sort of related. So can someone go from HER2 positive, ER negative to HER2 negative, ER positive?
So another good question, and there definitely are cancers that switch their subtype. It doesn't happen very much with HER2 positive disease. It's about 8% of patients switch from, or cancers switch from like a HER2 negative to go to HER2 positive when it recurs. But once a cancer is metastatic, there are some situations where the HER2 starts going down, the HER2 expression starts becoming lower, potentially going down to, you know, essentially negative levels with HER2 therapy. And that's potentially a mechanism of resistance that the HER2, that the cancer cell, you know, sees all of these drugs attacking the HER2, and they say, okay, well, let's just get rid of the HER2, and now I won't be sensitive to the HER2 drugs. And sorry if I'm anthropomorphizing the cancer cells, it's just an easy way to think of it. But we don't think that happens very much because the cancers really are dependent on that HER2 signaling. That's what made them cancers in the first place. So it's hard for them to lose the HER2 completely, but it probably happens in some patients that the HER2 levels start going down, but it doesn't seem to be that common.
Okay. What about if any of these drugs, will they be available for, or can any of these drugs be available for HER2 positive, but not for metastatic patients?
Yeah, so you know, because we were kind of focusing on metastatic disease today, I didn't really go over that, but now already we give, you know, for particular situations, we give not only trastuzumab, but we also give pertuzumab, and we give TDM1 in a subset of women who are patients who have HER2 positive disease in early stage disease, so non-metastatic. We give trastuzumab, pertuzumab, and TDM1 in depending on the specific situation. And there are trials going on right now asking whether these newer drugs like T-DXd or trastuzumab deruxtecan and HER2 or tucatinib, the pill, whether those drugs are help patients in newly diagnosed non-metastatic disease as well. So that's a great question. We are busily testing those, trying to answer that question, whether even these newer drugs can work in the early stage disease. But generally, we always try our drugs first in the metastatic patients because they're the ones who need it the most oftentimes. And then, and the trials in patients with early stage disease take many years to read out. So we always test first in the metastatic setting, and then we test in the early stage patients.
Good. We still have lots of good questions coming in. For those, if it says that it's been answered, stay tuned. It's in the queue to get answered. So one of the things is, someone's asking about their tumor markers. I know we talked about the antigens earlier, but if the tumor marker is always at a high level since they're metastatic, will the tumor marker always stay in the high level since they're metastatic?
Yeah, so I just want to kind of just clarify what tumor markers are. So tumor markers are proteins or molecules that some cancer cells make that spill out into the blood. And in some patients, you can use those to kind of give a sense of how the cancer is doing. So in some people, when their cancer cells are responding to treatment, their tumor markers go down. When their cancer cell, if the cancer cells gets resistant to the treatment, the tumor markers go up. And that can be useful for those patients because you can use that and kind of instead of having to do CAT scans as frequently or PET scans as frequently. But the tumor markers themselves have no clinical significance. They don't hurt anything. You could have, tumor markers in the tens of thousands and people could be perfectly fine. So all they are markers. All they are helpful in some people ways to kind of keep track of how the cancer is doing without having to do scans. But in general, we try not to use the tumor markers as a reason to change therapy just in and of themselves in patients. And there are some patients in whom tumor markers are not useful at all. Either the cancer doesn't make them, and then obviously you can't use it, and that doesn't have anything special about the cancer. It just doesn't make those particular tumor markers. It doesn't mean anything else. And there are some patients, perhaps like the one who was writing in, that the tumor markers just don't seem to correlate very well with how the cancer is doing. And in that patient, you just ignore them.
Yeah, and I think that's part of the reason. It's like a data point that you have that conversation with your doctor. I know some doctors don't like to measure tumor markers. So just having that conversation of
Yeah.
why should we do it? What information does it tell us? So.
Right. But yeah, exactly. And there are some, and just so, if you're someone who they're not doing tumor markers on, you could ask why, but there's lots of doctors who feel like they're just not even that helpful. And certainly for patients who don't have metastatic disease, tumor markers really aren't helpful. So they really aren't made to be followed for people who've never had metastatic disease.
Interesting. Good. That's helpful. What was the name of the trial that found that none of the heterogeneous cancers showed a complete response at surgery? You mentioned that in your presentation. What was that?
Yeah, I'm not very creative, and so I don't have a cool name for that trial. It was people just talk about it as the heterogeneity trial. It's published in a journal that it's more of a scientific journal. But it is in clinicaltrials.gov. If you look up TDM1 and probably heterogeneity, it probably would come up that way, or you can search it by my name. But yeah, I'm sorry, I don't have a good name for it, but it was presented at one of the big cancer conferences. I can't remember whether ASCO or San Antonio right now, but it is published, yeah, you can also search for the manuscript online, by looking for my name.
So we just have a couple more minutes left, so we're going to get to some final questions. Beyond tucatinib, are there drugs in development for HER2 positive brain mets?
Yeah, so I'm glad you asked that, because I saw that come up and I said, that's a great question. So there are other small molecules, we call them small molecules because they're pills and they're small chemicals as opposed to an antibody, which is a big molecule. So there are other small molecules like tucatinib that are being tested in the brain, and they some of them seem to work as well. But there's some real interesting data recently that even big molecules like in HER2 or trastuzumab deruxtecan, which we didn't think were going to work well in the brain because they're so big, it's hard for them to get into the brain because there's kind of a protective coating around the brain. Turns out that they seem to work in the brain as well. So I think we're going to have pretty definitive data in the very near future that big antibody drug conjugates also seem to work in the brain. And so I think for people who up till recently, we've been hesitant to use drugs like in HER2 or Kadcyla in patients with brain metastases or progressive brain metastases because we didn't think they would get into the brain tumor very well. But that probably turns out to be wrong. And there are data that are coming out recently, and there are going to be more data soon. They're going to show that those drugs seem to work as well. So there's new pills that are being tested for brain metastases, and the antibody drug conjugates also are probably going to be shown to be effective in that situation as well.
Good. All right. One final question. I think this comes up every time we talk about clinical trials, but is it true that some patients don't get a treatment or medicine, that they just get a placebo, which is like no drug in clinical trials?
A very important question. And Rebecca, thanks for bringing that up, because I should add that to my slide about clinical trials. So in cancer trials, we almost never use a placebo control as a treatment arm. So almost always, except in very rare circumstances and the really, diseases where there's no treatment available, which, almost never happens these days. But certainly in breast cancer, there's almost, I can't, in my, 25 years of doing clinical trials in breast cancer, I've never had a trial where there's just a no treatment control in the metastatic setting. And we do have trials that use placebo, but those are almost always trials in which both groups in a randomized study get a standard drug, and one group may get standard drug plus something else, and the other group may get standard drug plus the placebo. But again, that's because we're not sure whether we know that the standard of care drug can work, and we're not sure whether adding something to it is going to make it better or not. So everybody gets an effective treatment. It's just a question of half that would also get another drug on top of that. So I think, you might as well just, I think that the take home message is in every clinical trial for breast cancer, everybody gets a good proven, or everybody gets an effective treatment, or they get an investigational treatment that we think is going to be better, but we're not sure. That's why we're doing the trial. But everybody gets some effective treatment in a trial. Some people get an effective treatment plus an investigational treatment, but everybody gets an effective treatment, and everybody gets either effective treatment or something that we think is going to be effective, and we're testing it as part of the trial. So placebo is as a sole treatment is essentially never used in a metastatic breast cancer trial.
Well, thank you, Dr. Krop. We really appreciate the presentation, and I'll kick it back over to Casey.
Thanks for doing such a great job moderating, Rebecca.
Thank you to both of you. That was just an amazing presentation. You did a phenomenal job moderating. And to everyone who submitted questions and hopped in the chat, thank you for participating. I am so deeply sorry that we did not get to every single question. There just seems to never be enough time, and questions spur other questions, but I love the interest and the excitement. And I hope that you walk away today with at least some new or reinforced information that helps you move forward in your experience and your journey. So once again, we've got some thank yous in the chat, but I'll say it aloud. Thank you to Dr. Krop, and thank you to Rebecca for moderating. The session is being recorded, and it will be posted to our landing page soon. So you can rewatch this session or view any previous sessions if there's other content or topics that are of interest to you. So please help us spread the word about this important information with your friends, your family, your healthcare professionals, anyone you think might be interested or benefit from metastatic breast cancer educational resources. Once again, we're going to acknowledge our MBC Impact Series sponsors. Their generous support allows us to bring this content to you in the virtual setting. So a very special thank you to AstraZeneca for being the technology sponsor for this year's series. Also, our premier sponsor, GE Healthcare. And last but certainly not least, our signature sponsors, Walgreens, Sanofi, Daiichi Sankyo, and Merck. They are why we're able to bring this information to you. So please also help us by completing a survey, which we will place in the chat feature. It's very important and helpful for future program planning. And by completing the survey, you'll be entered in to win an Amazon gift card. So finally, the next event, the MBC Impact Series event, will be on April 26th. And it is the final part of our 4-part research series, and it will focus on MBC and inflammatory and lobular breast cancer. So we look forward to having you log in and join the conversation. Thank you again for joining us today, and thanks to all that made this event possible. Stay safe and stay connected.
Thanks, Casey.